Oh, there we go. Hi.
Hi.
Koli, sila na pota lupa bitin na kala siya. Sal ipapagaya la. Mapitin na machine na.
Wow, Mr. Paul, what's going on?
Can anybody hear me?
Yes.
Yes, sir.
Yes.
Yeah.
All right, can we resume now?
Yes,
Yes.
sir.
All right. So I left chapter 37. I went to chapter 20. Let's do anaphylactic and neurogenic shock next. My chapter 20. All right, so this will be quick because this is the same emergency. So we had cardiogenic shock, which was very quick. Because do you have a lot of time to attend to cardiogenic shock?
No.
No, same thing here for anaphylactic shock. So this requires prompt intervention. This is an emergency, so this will also be very quick. So obviously this is under chapter 20 because this is falling under hypersensitivity reactions. So the three distributive shock, the three types of distributive shock, namely anaphylactic, neurogenic shock, and septic shock, are all blood vessel problems. What was the common mechanism that happened so far? We have talked about obstructive, cardiogenic, and hypovolemic shock. What were the responses in those three types of shock? What was happening? So when the blood pressure dropped, what was the response?
Sympathetic
Sympathetic response, right? So all the responses were what? Was there vasoconstriction or vasodilation?
I think constriction.
There was, in all those three, there was vasoconstriction, correct?
Yeah.
So,
Yeah.
so this is the one that's weird about distributive shock. So let me illustrate it. So if we had in those three types of shock, the blood vessel constricted, correct, in response to sympathetic stimulation rather. So if this is your blood vessel, cross section of a blood vessel, so let's say this is the normal diameter, and this is a constricted blood vessel, meaning the walls dilated, right? So because blood vessels are muscles too, they are smooth muscles. So if they constrict, that means the diameter will narrow, correct? And opposite that would be, this would be dilation. So if the blood vessels dilate, it would of course enlarge the lumen. So this is decreasing afterload. This is increasing afterload, meaning the resistance. Okay, and this is a normal diameter blood vessel. So normal response in shock is, of course, vasoconstriction. So the sympathetic response was vasoconstriction in order to increase resistance, peripheral resistance specifically, to raise blood pressure. Now, this is the normal response that we will constrict the blood vessels. Not so in anaphylactic, septic, and neurogenic shock. What happens instead is there is vasodilation. So is this a normal response? Meaning that's why they call this a distributive shock. Is what was the purpose of constricting the blood vessels in the sympathetic stimulation? What was the body trying to do?
To compensate?
Well, there is a generalized peripheral, specifically in the peripheral vessels, there will be vasoconstriction. Why did the body do that? Why are we constricting peripheral blood vessels? What is it trying to do to the blood?
It's trying to, I guess it's trying to hold on. It's trying to prevent loss.
Right. It's trying to shunt the blood only to the three organs again. I kept saying this, only to the brain, the heart, and the lungs, right? So, because these are the most vital organs in an emergency. Now, would it make sense to you to dilate blood vessels so that the blood, instead of being shunted only to these three organs, it will now go to all the organs, including the skin? Because if you dilate blood vessels, even non-vital organs such as the skin will now receive blood. Is that a proper response?
No.
No.
No. The proper response is to distribute blood only to the vital organs, only to these three organs. But what happens in anaphylactic shock, in septic shock, and neurogenic shock is there is widespread vasodilation in such a way that even the skin, the hair follicles, receive blood supply. So that's why what happens in angioedema. So here in your textbook, look at this patient here. They are in shock, but look at their color. Instead of turning pale and their skin feeling cool and clammy, they turn flushed, they feel warm, but because they are in shock, the blood pressure drops. Okay, so what is this a proper response to low blood pressure?
No.
No. Okay, so this is, if it was up to me, the name should really be maldistribution. So this should really be maldistributive shock, because this is not the correct maldistribution. Okay, so there is incorrect allocation of resources. So in shock, we're supposed to conserve resources, conserve blood and oxygen only to these three vital organs here. But what happens in anaphylaxis, in septic shock, and including neurogenic shock, is there is maldistribution. Instead of vasoconstriction, what we have is vasodilation. And that is what accounts for the patient's symptoms here. So the mechanism started from hypersensitivity. So of course you are either hypersensitive to a drug, food, or any other substance, correct? And that triggered a systemic inflammatory response, causing your blood vessels to be leaky, specifically your capillaries. We call that capillary leak syndrome, if you remember that term. Okay, so the patient goes into a increased capillary membrane permeability, okay, because of your hypersensitivity to that substance, whatever you're allergic to. So the first response or the first manifestation, of course, will be angioedema. So the angioedema here, why does the patient look like this? Are the vessels constricting or dilating?
Constricted?
Dilating.
They are dilating. That's the only explanation why there is increased blood flow to the skin.
Mm.
Okay? So to illustrate, if your blood vessels are dilating, so let's say this is your trachea. Okay, this is your, I cut off Bio's head, okay, and I'm looking down his neck and I'm looking down his trachea. So the trachea is a smooth muscle, correct? Yes, no?
Yes.
Yes. So why is there bronchial constriction when you have vasodilation? This is your airway. Why does the diameter of your airway narrow when there is vasodilation?
Is it because of the spasm?
Okay, so therefore, if you have dilation, because the wall, so let's say this is the normal diameter of your airway. Okay, so this is the thickness, normal thickness of your trachea. If the blood vessels supplying this smooth muscle here all dilate like this, what will happen to the diameter of the tracheal muscle?
It's smaller.
It will,
Gets
will
smaller
it will,
because
Okay, so let's say this is the blood vessel. Okay, this is a capillary or an artery or a vein or in here. Okay, and this is supplied with blood vessels. If all of them dilate like this, what will happen to the diameter of the wall, the thickness of the bronchial wall?
it's gonna get smaller due to a lot of perfusion in the area.
So the wall will get narrower like this because you said it will get smaller.
Right.
Again, the blood vessels are dilating. So every single blood vessel here is
will,
now dilating, filling with a lot of blood. So what
will,
will happen to the wall? Will it go like this or will it go like this?
no, it will increase. The walls will increase in
Okay, so
size.
right. So the bronchial wall, the muscle, the diameter will increase. As a result, it will narrow the airway. You see the concept?
Yes.
Meaning because of vasodilation of these blood vessels supplying the bronchial wall, it will not narrow, but rather widen the wall. However, what happens to the opening?
Get smaller.
Gets smaller. So you see the concept of how vasodilation or how generalized vasodilation constricts the bronchial wall. I mean, the narrows the bronchial your airway because they
Yes.
thicken. Okay, so they thicken because all the blood vessels are dilating like this. So therefore, it will narrow. So this is all because of severe inflammation, severe vasodilation occurring. That's why this patient right here looks like how she does. But she may look good, right? I mean, her color is nice, but what's happening to the diameter of her airway here? It's getting smaller. So that's why you have
Close.
shortness of
Inside
breath.
it's getting smaller.
Yes, so that's why you have the wheezing, you have the difficulty breathing right here. So you have difficulty speaking, drinking, swallowing, or even breathing. Understood? Question.
Yeah.
All right, so let's go now to the manifestations, of course, are here. So you have these swelling. So you'll have lip swelling. Who has anaphylaxis here? Who are seriously allergic to something?
I've experienced it once, and it was due to rain. Rainwater just dropped on me, and I just got allergic to it that day.
Really? What are you,
Yes.
gremlin?
I was I was in a village back home. You know, like after college, I had to go for compulsory assignment somewhere far into the remote side of Nigeria. So it happened that
How
night.
about now?
Now, no, I don't. I'm not
Okay,
allergic
good.
to
Yeah.
rainwater.
I hate gremlins. All right, let's go to interventions now. So this is an emergency. Do we have hours to attend to this patient?
No.
No, anaphylaxis is an emergency. So what is your first intervention? So our summary is here, chart 20-1. Well, no, this is the use of epinephrine. Sorry, it's 20. It's the next chart, 20-3. Sorry. So it's 20-3 are your interventions. So in this particular order, you assess airway, then call for help, and then ensure that the crash cart is nearby because you may need to intubate the patient, give oxygen, and then we give epinephrine. If they don't have an IV, they should have one. Let me make a modification of this chart right here. And of course, this will be supported by, this is 365. This will be supported by the summary down here. Let me see if I can find it. I can't find it. Okay, so let's go back here. All right. So does it make sense that you stop the drug after 1, 2, 3, 4, 5? This will be your fifth action instead of the first?
No.
Okay, so if you were to make modification on this chart, what would you do first?
Stop the drug.
Stop the drug. Okay, so it really depends on the scenario. So let's say this is a reaction to an antibiotic. So you're giving the IV antibiotic for the first time, and then the patient shows signs and symptoms of anaphylaxis. What will you do first?
Stop the antibiotic.
Right. What did you learn in chapter 40 under blood transfusion reaction? What were you asked to do?
Stop the drug.
And
Stop the transfusion.
Transfusion. Okay, so I rest my case. So if I put this in a sequencing order, which action would you do first?
Stop the
Of the
drug.
antibiotic.
The drug, and then you continue with the others. You assess airway, call for help, etc. Are we clear?
Yes.
Yes.
Okay, so I'm glad we got that understood. So after you do that, so you stop the drug, you assess airway, call rapid response, get the, well, you can't leave the patient, so you just have to ask somebody to yell for help. Okay, so get the equipment, the crash cart in there in case we need it. Then you put on the oxygen, and what drugs will be given? First,
Epinephrine.
Epinephrine.
all right, it's always epinephrine. This is the concentration. This can be repeated every 5 to 15 minutes because this is short acting. So there may be what they call a rebound, another rebound reaction after the epinephrine wears off, so you can repeat the dose. Why do we raise the patient's legs?
for circulation to return the
Return, venous return.
return. Yeah.
Venous return, because that will help increased blood pressure. Why can't we elevate the head of the bed? They only put here if the blood pressure is low, hypotension, obviously that's below 90 systolic. Why can't we elevate the head?
Because that will further drop the pressure. If
Very
you raise the
Reduce the intracranial pressure and stuff.
no. This will drop your blood pressure. Remember chapter 36 under malignant hypertension or hypertensive crisis, chapter 36? There was a chart there, emergency management of hypertensive crisis. What was the first action on that chart? If anyone remembers.
Increase the head of the bed, elevate.
Yes, it was elevate the head of the bed or place the patient in a sitting position.
90 degrees.
What about under autonomic dysreflexia? Was that an emergency also?
Yes.
Yes, it was another life-threatening hypertensive emergency. What was the first action on that emergency chart under autonomic
the
dysreflexia?
patient up.
The same thing. Elevate the head of the bed or put the patient in a sitting position. So therefore, you had two charts there saying the same thing in both hypertensive episodes. So therefore, in the same way here, what will happen if you elevate this patient's head?
Drop in pressure.
It will drop the blood pressure. Understood?
Yes.
All right. And then after, do we stop at epinephrine? No. So what
No.
is the other drug that will be given after epinephrine? What will be given next?
Antihistamines.
Okay, so we give Benadryl, diphenhydramine, IV or IM. What others? What other drugs will be given? So
Maybe
we give epi, then Benadryl, and then next.
albuterol.
Well, we
if we need.
Yeah, so you can give albuterol, and of course, can we give a steroid also?
Yeah.
Yes, steroid dose will also be added. Let me point that out. Where is that? We have the bronchodilator. And where is the steroid? I can't see it right now, but it's somewhere here. Oh, right here. Just look, he was about to slap me. Corticosteroids are added to emergency interventions, but they are not effective immediately. So that's why you don't go for the steroids first, because will this work right away?
No.
No, the patient will be dead before this thing dilates your bronchus. So we always go for epi first, because that will counteract the massive vasodilation that is happening. So that will be replaced instead with vasoconstriction. Then you have diphenhydramine, which is your antihistamine to stop the inflammatory response. And then you give your bronchodilators, and then you add your steroids, okay, for longer term effects. Because the diphenhydramine will only have, again, another short-term effect. So steroids will make sure there will be a decreased inflammatory response. And that's it for anaphylaxis. Next is, let's go to neurogenic shock. That will be chapter, I want to say 40, 42, 43. No. Well, let's try 43. It's 43. Okay, spinal cord injury. You did this last semester, correct? That's why you had, what was the name of your spinal cord injury patient that semester? For autonomic dysreflexia? David Montanari? Yeah?
Sure.
Okay, that was David Montanari. Neurogenic shock is a very short section here on spinal cord injury. Let's see. Right here. Oh no, that's not it. Okay, here. It's a small critical rescue box. This is different from spinal shock, okay? If you remember spinal shock in this chapter, spinal shock is a temporary loss of neuromuscular function, correct? Below the level of injury. This one is the true medical emergency. Neurogenic shock can result after or following acute spinal cord injury. And of course, you have to know the symptoms and then your action, of course, if you see these symptoms, namely, what are they, Miss Javiera?
Bradycardia, a low oxygen,
And
and your blood pressure that's low.
okay, so these are your three symptoms that indicate the patient is going into neurogenic shock. And what is your first action if you find if you see these findings?
Call the provider.
That's it. So don't be a hero. Call the doctor. You see these symptoms, call the doctor immediately. And of course, this is spinal cord injury. So again, prepare the crash cart because we were going to have to intubate the patient. And what do we do about the bradycardia? This is now a symptomatic bradycardia because the blood pressure is low. What drug is used to treat symptomatic bradycardia?
Atropine?
Atropine.
0.5.
Atropine.
Atropine.
Right. But before that, of course, how do we raise the blood pressure here? Because the patient has, so after notifying the provider, what do we apply? Which is applicable to any patient? Do you give oxygen?
Yes.
Okay, oxygen, and then of course we start increasing the blood pressure by giving fluids first. However, if they don't respond to the fluids, what will be added? Hello? Okay, we will add vasopressors. Give you an example of a vasopressor.
Desmopressin.
No.
No.
In this instance, okay, dobutamine, dopamine will be added. So right here, dopamine or another vasoactive agent, another vasopressor. Here's atropine to treat your bradycardia. And that's it. We just took care of patient in anaphylactic shock and in neurogenic shock. Why were they very short?
Because they are emergency.
Right. We don't have more than 15 minutes to take care of it. We only have a narrow window. That's why the discussion is very short. Any question?
Professor, you said for bradycardia, okay, you give atropine. You saying give that first, or you're saying it's just one of the emergency treatments?
Well,
and then
there's I mean, in these instances here, are there several minutes between interventions? I mean, between
No.
giving oxygen
No.
and starting.
No.
No, they're almost like given the same, right? Plus, are you the only one attending to this patient?
No.
No.
No, there's a whole village in that room. So the moment you notify a primary healthcare provider, this can also be instead of the PCP, who may be in the barber shop. So there's no way this doctor will be of use to you. So who else can you call when you see these in a patient with spinal cord injury?
The respiratory
Well,
therapist.
be the respiratory therapist. What can the respiratory therapist do for you? He can't give orders.
Can't call anybody.
Who do you call in the hospital?
You call the doctor. Basically.
Rapid response.
Rapid response.
Oh yeah.
So instead of the primary care provider, it can be the rapid response. Okay.
Okay.
All right. Any question?
No, Professor.
No.
Alrighty. It is 8:23. I don't know if we can finish shock. I'll try, but I'll have to end this meeting because we will be cut off because I only have 8 minutes. So I think we can finish it. Okay, so I'll stop this session. Just log back in. Okay.
Okay.